Hello, and thank you for attending today's webinar, The Potential Role of Airway Oscillometry in Early Phase Respiratory Trials, presented by ERT. Before we begin, we wanted to cover a few housekeeping items. At the bottom of your audience console are multiple application widgets you can use. If you have questions during the webcast, you can click on the Q&A button at the bottom and submit your question. We will try to answer these during the webcast, but if a fuller answer is needed or we run out of time, your question will be answered later via email. We do capture all questions. If you have any technical difficulty, please click on the Help widget. It has a question mark icon and covers common technical issues. An on-demand version of the webcast will be available approximately 1 day after the webcast and can be accessed using the same audience link that was sent to you earlier. Our speaker today is Professor Salman Siddiqui, Professor of Airways and Disease and Respiratory Medicine at the University of Leicester and the NIHR Biomedical Research Center at Glenfield Hospital in Leicester, United Kingdom. With that, I'd like to introduce Professor Siddiqui, and welcome to the webinar.
Thank you very much, Chris. So what I'm going to do is, over the next 40 minutes, take you through the background to the forced oscillation technique, really to give you an insight into what the technique measures, drawing some parallels with spirometry, but telling you how it differs as well, what additional information, if any, technique may have to offer. I'm then going to go through some translational case studies to give you an insight into how measurements that are derived from FOT relate to imaging measures, for example, in the lung, whether FOT measurements may tell us about the small airways in the lung, which is very topical at the moment in respiratory disease, and a case study looking at the role of FOT in phase 2 clinical trials. And then really the remainder of my talk will be, the webinar will be on the future directions of FOT. So what are additional potential applications, areas of unmet need? So these are my disclosures. Okay, so let's start. We're going to talk about the background of FOT and what it measures. And before I start, I just want us to reflect on spirometry, which we all use in clinical practice, I'm sure, on most days of the week. The advantages of spirometry are obvious. It's an established classification tool. It's epidemiologically robust. It's well standardized, and it's got robust normative data. So large initiatives such as the Global Lung Function Initiative with multi-ethnic and life course normative data for the technique. But I think we have to be cognizant of the disadvantages as well. Spirometry is effort dependent, as we know, and that often locks out the technique from populations such as patients with severe exacerbations of respiratory disease and other populations. Furthermore, to do a high quality spirometry test, on average, takes about 20 minutes of measurement time with a physiologist. We all know that spirometry is not particularly suitable at the extremes of age, particularly in early school age and certainly preschool children and the very elderly in some cases. And we also know that spirometry is largely insensitive to disease in the peripheral airways of the lung. And we know that many airway diseases, specifically early COPD, asthma, potentially other diseases such as interstitial lung disease, are deeply rooted in pathological problems that arise from the small airways. Let us consider the forced oscillation technique. How does it compare to spirometry potentially? Well, I very much see this as an adjunct to spirometry. Here is a tool that is effort independent, so you breathe tidily using this device, and I'll talk about the device in a moment. So there's no effort required. Testing time is very short, so you can get triplicate measurements with the FOT technique in under 2 minutes in a patient. So there's a substantial time advantage. The technique is proven to be valid and useful in preschool children, and it's useful in other populations that I mentioned that may be difficult to test with spirometry, particularly patients that are elderly, tracheostomized patients potentially, but also patients that are having acute and severe exacerbations. And furthermore, as you'll see in my talk, there is evidence that the FOT technique is sensitive to the peripheral airways. There's mounting evidence. There is a disadvantage, which is that FOT currently lags some way behind spirometry when it comes to normative data, although efforts are underway for standardization. I'll mention that in my talk. So, what's the principle of FOT? And this is really highlighted on this slide here. In the top bar, you can see the normal acoustic range of human hearing. That's the green. So humans hear between 20 to 20,000 hertz. That's the normal hearing range. And for those of you that are, familiar with different audible ranges, you'll know that bats can hear at very, very high frequencies, and rhinos and large mammals, such as elephants, can hear at very low frequencies. And actually, FOT perturbs the lung. It's an oscillatory technique where a pressure oscillation perturbs the lung and the respiratory system at a frequency envelope between 5 and 37 hertz. So it extends below the audible hearing range, so the infrasonic range, but it also extends into the hearing range. And you can see that to just benchmark this, I've put an annotation of a piano here, and you can see that a piano's frequency range starts around 26, 27 hertz in the audible human hearing range. So FOT is a technique that is largely related to infrasonic, sub-hearing, hearing range, pressure oscillations of the lung to perturb the respiratory system and lung mechanics. And I'll tell you how the measurement works on the next slide. So how does FOT work? So if we think about the device at the bottom of this screen, where my mouse is, this is a TREMOFLO device. The device has a small piston inside it. Technology used to involve very large loudspeakers, but the advantages of piston-based technology have now been realized in this field with these very small fieldable devices that generate a pressure oscillation. So that piston oscillates at a frequency forward and backwards, and that generates a pressure oscillation in a patient while they're breathing. Now, the pressure oscillation is seen by the airway gas column, the airway wall, the lung parenchyma, the chest wall, and the cheeks, particularly if the cheeks are not held. It will be shunted, damped by the cheeks. But if the cheeks are held, the pressure oscillation will be transmitted into the lung. And the system, the FOT system, has a pneumotachograph, a pressure and a flow meter at the airway opening that measures the response of the respiratory system to that pressure oscillation. So it measures the pressure and the flow as a function of time. So here you have a patient that's breathing. The flow related to breathing is subtracted from the pressure oscillation, and what you measure at the mouth is the response of the respiratory system. So that's the airway gas column, the lungs, the lung parenchyma, the chest wall, in response to that oscillation. You measure pressure and flow over time. Now, the pressure divided by the flow at any particular point in time gives you something called the impedance. And one area of FOT physiology that some folk find difficult to understand is how you get from impedance to, as a function of time, to resistance and reactance as a function of frequency. And it's very, very simple, actually. So the impedance is made up of both the resistive part of the lung and also the reactive part of the lung. And essentially, the resistance you'll all be familiar with measures the damping of those pressure oscillations through the airway tubes due to narrowing. But the reactance tells you about how in or out of phase the pressure and the flow are when the pressure oscillations are transmitted through the lung. And I'm just going to describe the measurements that are achieved. So if we flick back, So if we take the impedance as a function of time, a simple technique in signal processing that's very, very common called Fourier transform is applied to the technique, which then gives us the impedance as a function of frequency. So those pressure oscillations are broken down into the different frequency components. And usually in FOT, as you saw in the last slide, the frequencies that that signal contains are somewhere between 5 and around 35 Hertz. Okay? So what we can see here now is the resistance and the reactance plotted on the y-axis and the frequency on the x-axis. And you can see that the data spans from 5 Hz to 35 Hz, which is the information content of that oscillation. Now, the FOT tracing is very, very simple if you apply a pattern recognition approach to it, which is very much what you do every day with spirometry. The key measures to be aware of that the technique measures are the resistance at 5 Hz, so at lower frequency. And this is a measure of total airway resistance. The lower frequency oscillations probe deeper into the lung and are reflective of total airway resistance. Then if we go to 20 Hz, we can measure the resistance at 20 Hz. And this is a measure of central average airway resistance. And the difference between the resistance at 5 Hz and the resistance at 20 Hz, the R5 minus R20, or dependent upon the device, maybe the R5 minus R19, may tell us about the peripheral airways of the lung. So that's resistance, which we all find intuitively straightforward. Now let's talk about reactance. Well, there's a point on the FOT tracing when pressure and flow are completely in phase. They're like a husband and wife walking down a park avenue on a sunny day, holding hands. They're perfectly synchronous. And the pressure and flow are in phase and the system is at resonance. There is no reactance component. That's the resonant frequency, or FRES. The system has a pure resistance. But under or at lower frequencies than the resonant frequency, pressure oscillation lags behind the flow and the system has an elastance. And I'm going to talk about that in a moment. Frequencies above the resonant frequency, the pressure oscillation leads the flow and the system is inertive. What does this mean? Well, the reactance is equal to the inertance, which is the inertance that the airway gas column provides to those pressure oscillations, minus 1 over the capacitance. And it's the 1 over the capacitance that you have to understand why you have a negative number for reactance. So when the lung becomes closed due to mucus plugging or loss of elastic recoil or loss of airways due to emphysema, bronchoconstriction and airway closure, or it becomes very stiff due to pulmonary fibrosis, the lung will have less capacitance to store those pressure oscillations. And as a result, the 1 over the capacitance term will become larger. So that it will, because it's inertance minus 1 over the capacitance, it will become a larger negative value. So as the lung becomes stiffer, we lose elastic recoil, this number x5 will become more negative. And the area under the curve between 5 Hz and resonant frequency, which is called the AX, named after Mike Goldman, or Goldman's triangle, is a marker of the same problem, a loss of elastic recoil or increased lung stiffness. So those are the core measurements to summarize. The total airway resistance at 5 Hz, central or average airway resistance at 20 Hz. The difference between 5 and the 20 Hz resistance tells us about the peripheral airways. The X5 telling us about the stiffness or elasticity of the smaller airways. The resonant frequency, which gives us an index of that. The further it's shifted to the right, the more loss of lung elastic recoil that there has been, the stiffer the lungs, further to the left, the less. The same thing is captured by the reactance area. Those are the core measurements. I'm going to move to the next slide now. So what does a good FOT test look like? Well, here's a patient in my, a physiologist actually in my lab doing an FOT test. And you can see that she's holding her cheeks. So that's very, very important. So you have to keep your head slightly neutral or sniffing the morning air but not flexed. If your neck is flexed, and you'll provide an unnecessarily high upper airway resistance to the pressure oscillations. You need your head in a nice neutral posture. You need to hold your cheeks firmly with your thumbs underneath your mandible, and the FOT device put into your mouth with a mouthpiece, having been calibrated with a standardized volume and standardized resistance. And the patient in this picture starts by just breathing their normal tidal volume and quietly breathes at this volume for about 30 seconds. And this is important because FOT is very, very sensitive to what your lungs have been doing. So if you've been taking very deep breaths or doing forced expiratory maneuvers, you need to allow some time for the FOT, for the lung mechanics to stabilize. And it usually takes about 30 seconds, quiet tidal breathing, to do that before you have a test. If you've done any forced expiratory maneuvers, it can take a few minutes, 3 to 5 minutes. So now the patient is holding their cheeks. They have to have a nose clip on again so that pressure oscillations don't leak. And the recording is very short. It's somewhere between 16 and 30 seconds, depending upon the device that is used. Typically, we take 3 to 5 tests. These are interrupted tests, so you come off the mouthpiece and have a break before you have the second test. And the measures of quality are very, very simple. We look at the coefficient of variation of the impedance, or the ZRS, and the resistance, typically at 5 Hz. This is typically less than 15%, and with a very good test, it should be less than 10%. And we also look at a measure of the linearity of the pressure and flow signal as they're applied to the lung, and this is captured by a term called the coherence. All it measures is the linearity of the pressure and the flow. The coherence should be above or equal to 0.8 at frequencies of 5 Hz and above. So that's what a good test looks like. We're now going to move to the next slide. And I mentioned earlier on that there are a number of patterns that you just need to be familiar with in terms of pattern recognition to understand FOT. And here we've given these to you as a schematic with the spirometry on the right-hand side, and then the FOT with the resistance on the panel on the left, and in the panel in the middle, the reactance. So in a normal lung, you've got a normal flow volume loop, and you can see that you have a relatively flat recording of resistance across the whole frequency range. You can see that the resonant frequency is low, it's between 5 and 8 Hz. You can see that that reactance area that I was talking about is very, very small. Now, in people that have peripheral airways obstruction, so let's say that this patient is a patient with bronchiolitis, the first thing that happens is that you get this frequency dependence of resistance. So essentially what that means is that at the lower frequencies you have a higher resistance and it rapidly starts to slope off, so that the R5 minus R19 or 20 will increase. And on the reactance side you can see that the resonant frequency has shifted to the right hand side, and as a consequence the reactance area, the AX, has increased. Spirometry in this patient shows classical scalloping of the expiratory limb of the flow volume loop, and this is a classical patient that has airflow obstruction, possibly driven by disease in the peripheral airways. You might ask, well, how do you differ that from proximal airway obstruction? Well, let's say you have a lung cancer, including your right main bronchus. What you'll then see is actual a raising of the resistance across all of the frequency components of the signal, as seen here. You will not see an impact upon the reactance. And here you can see the classical flow volume loop of a patient with extrathoracic obstruction. Finally, you have a patient with restrictive disease, and typically you do not see significant changes in the resistive component in restrictive disease, so pulmonary fibrosis, but you do see the shift in the resonant frequency, and the reactance area increases, indicating a stiff lung that has a low capacitance for those pressure oscillations. You have the classical spirogram. So actually my clinical practice is to use FOT alongside spirometry, and it aids with the interpretation of lung disease that I see. It's a very simple tool to do that. Let's move on. One of the criticisms of FOT is that it's noisy as a measurement, and this is actually a false criticism. Here's some data from a study that we published a little while ago, European Respiratory Journal. This is data in moderate to severe asthmatics, and here we've got the within visits, between visits, so over 2 weeks, and over 3 months repeatability of a range of pulmonary function measures, so FEV1, mid-expiratory flows, the FOT measurements that I've talked about, but also the lung clearance index, which is a measurement that you'll have heard about that's being developed in cystic fibrosis as an endpoint for ion channel modulators. And you can see very clearly that the intra-class correlation coefficient, which is a measure of the repeatability, is actually very good both within visits and between visits, 2 weeks and 3 months, for all FOT data, and it's as good, slightly inferior, but it's as good as spirometry. So it's a highly repeatable test if you do it correctly. So let's move on. What about reference values? So I think this is work in progress. FOT does not have the body of data that spirometry has in terms of normative values, but actually, reassuringly, there is now good normative data from published studies in populations that may be relevant to clinical trial cohorts. This study by Schultz et al. Is probably one of the largest normative population studies. It's a German cohort of just under 400 patients, aged between 45 and 91 years of age. And in this study, they used quantile regression, because FOT data is notoriously non-parametrically distributed, to generate normative equations for FOT data. And what this study found was broadly consistent with all of the other normative studies in the field. So firstly, women generally have larger resistance values across the frequency spectrum when compared to men. Secondly, the reactance tends to be lower or more negative in women at the lower frequencies when compared to men. Thirdly, the age has a significant impact upon the small airway parameters, R5 minus R20, AX, resonant frequency. And finally, weight has a significant impact on FOT normative values, particularly in females. We are yet to understand fully how ethnicity, so non-Caucasian ethnicity, impacts upon FOT, and certainly this is an area that requires further development in the FOT field. But normative data is there for reasonably sized cohorts. Okay. What about the comparison of FOT between devices? Do devices measure the same thing? The answer is that, broadly speaking, the two commercial devices on the market, the iOS system and the TREMOFLO device, are very, very similar in terms of their measurement properties, as can be seen from this study, which is under review in scientific reports, where we've compared the measurements of iOS and TREMOFLO in asthmatics, healthies, and asymptomatic smokers. We've just got some representative data here. But essentially, you can see that across the earlier frequencies, between around 5 and 20 Hertz, the measurements are broadly similar in the smokers and the asthma population. There is a slight difference in the resistance values between iOS and TREMOFLO at the lower frequencies in healthy subjects, however. I think the important take-home message from this is to use the same system in a clinical trial, whether it's an observational study or whether it's an interventional trial. Don't mix and match between devices in a trial. I think that's a no-brainer, but it's clearly borne out by the data. Okay, so what do these measurements mean? Do they actually really tell us about the small airways? So a while ago, we embarked on a European Union-led program called AirProm, Airways Disease Predicting Outcomes through Patient-Specific Computational Models, where we use the full power of computational simulations and imaging to understand what FOT measures mean. And in the next few slides, I'm just going to summarize a few headline points in no great detail from the results of those studies. The first slide is from a computerized airway tree model that you can see here. This is derived from a CT scan that's been segmented to the 6th airway generation. The branching algorithm has then grown out these airways to fill the lobar volume down to the 16th airway generation. And in a computer, the small airways less than 2 millimeters in diameter have been constricted either by 20%, 50%, which we call severe constriction here. And what we can see here is the contribution of the central airways in the model, the small airways in the model, and the upper airway shunt, which I told you about, to these measurements R5, R20, and R5 minus R20. And the key take-home message here is that in the presence of no disease, so no baseline bronchoconstriction, the R5 and the R20 are relatively equally attributed to both central and peripheral airways, with a small but significant, are relatively equally contributed to the small airways, with an equivalent contribution to the central airways and a large contribution from the upper airway shunt. However, when you start to see bronchoconstriction or remodeling in the lung, particularly when it's severe, you can see that the small airways then dominate the contribution to both R5 and R20, but more so to the R5, such that when you look at the difference between R5 and R20, so the R5 minus R20, you can see that there's this increase across the spectrum of bronchoconstriction, from healthy lung to mild to severe disease. The take-home message from here is that the computational models told us that these measurements that we seem to be reporting suggestive of early or small airways disease do in fact relate anatomically to disease in the small airways. How does FOT data relate to imaging? This is data that's under review at the moment, looking at functional imaging with CT scans that have been taken at 2 lung volumes, but FRC, that's functional residual capacity, and TLC. And the pixels in each of these images have been registered using a technique called parametric response mapping. And what we've modeled here is the change in Hounsfield units as the lung deforms from FRC to TLC on a pixel-by-pixel basis, and a biomarker called functional small airways disease. And essentially, if we take the very simple biomarker, the change in Hounsfield units, or the del-HU, which is a measure of how much ventilation there is, here you can see a healthy patient where, as you'd expect, when they're lying down, most of the ventilation is in the lower lobes of the lung, where there's the biggest mass of lung. And you can see that by these hot spots in the del-HU in the lower lobes that are circled. And you can see that there are very low levels of functional small airways disease. It's all blacky, dark orange, and it's evenly distributed in the lung. And this patient has a normal R5 minus R20, and if you look at the gradient of del-HU from the bottom to the top of the lung, which is that thing right at the top, del-HU with a negative integer, you can see that the ventilation is increasing from the bottom to the top. What we found is that in asthma, when you start to have an abnormal R5 minus R20, you get a reversal of the normal ventilation gradient in the lung. So essentially, the ventilation seems to now be localized to the upper and middle lobes of the lung and is actually reduced in the lower lobes of the lung, with a greater amount of functional small airways disease in the lower lobes of the lung. So the interpretation here is that increasing R5 minus R20 and peripheral airways disease measured with FOT tells us about the evenness or unevenness, in this case, of ventilation in the lung. And certainly in asthma, it may be indicative of ventilation gradient reversal in the lung, which is an interesting observation that may have an important impact on aerosolized aerosol inhalation. Next slide. Now we're just going to talk about the deployment of FOT in clinical trials. So I want to take you through a case study in asthma. So we know from some of the published inhaler studies that the effect size on R5 minus R20 when you give an inhaled corticosteroid, either an extra fine particle compared to a non-extra fine particle, an inhaled steroid that has a lower mass median aerodynamic diameter to another one, that the average effect size that you'll see with the inhaled steroid is a difference between one steroid and the other of about 0.03 kPa second litre to the -1 in R5 minus R20. Standard deviation of that effect based upon data from our own moderate to severe asthma cohorts, is about 0.05 kPa second litre to -1. So if you were to conduct a multi-centre phase 2 asthma trial, you were to power it at between 80 and 90%, with an alpha of 0.05, you'd need between 45 and 60 patients per arm to be powered for R5-R20 as an exploratory endpoint. And so we went back and looked at 2 published RCTs in this area. The first was a single-centre phase 2 trial of fevipiprant, which is CRTH2 receptor antagonist in moderate to severe asthmatics. The primary endpoint in this study was the impact of fevi versus placebo on sputum eosinophils. So this study enriched patients that had a sputum eosinophilia at baseline. It was a 12-week study. There were 30 patients per arm. The second study was a monoclonal antibody trial of tralokinumab, anti-IL-13. This was multi-centre phase 2, again randomised, double-blind, placebo-controlled in moderate to severe asthma, again over 12 weeks. Again powered to look at eosinophils, but this time in tissue, and this time approximately 40 patients per arm. Now, we wanted to look at the impact of the pooled impact of these anti-inflammatory agents on FOT endpoints, and as I've already told you, neither trial alone was powered to detect a signal, because as mentioned in this earlier slide, we'd need around 60 patients per arm, which was larger than any individual study alone. So what do we see with FOT in these trials? So what you can see is, as I've mentioned, there's an effect size of about 0.04 to 0.05 kPa second litre to the -1 for R5-R20, comparing anti-inflammatory therapy versus placebo. Neither study shows a significant effect, but the pooled estimates give you an effect of about 0.04 kPa second litre to the -1, favouring anti-inflammatory therapy against placebo. I think this data suggests that not only can you deploy FOT, as we did in these 2 trials, both in single-centre and multi-centre phase 2 anti-inflammatory trials. FOT was an exploratory endpoint in these trials, but more so, if the trial is adequately powered, this technology may give you an insight as to whether the drug is treating the small airways. Okay. So what are other potential applications of FOTs? We've talked about asthma, and I've given you a case study. I'm going to talk to you a little bit about COPD. This is a slide that's courtesy of Ron Dandurant, who is a practicing primary care physician in Canada. And this is one of his patients. And here's the patient with early Gold 1 COPD. So they've got an obstructive ratio, but a normal FEV1% predicted. And no evidence of emphysema. LAA stands for low attenuation areas in the lungs. This is completely normal. So it's got a pristine CT scan, pretty good spirometry with very early airflow obstruction, as you can see on the right-hand side of this figure, with an obstructive ratio but a normal FEV1% predicted. Look at this patient's FOT. I'm going to signify the AX here, which we've squiggled out. And you can see that this patient has an AX that is almost 15 times the predicted AX that you might expect in this particular patient. So there's an enormous increase in the reactance area, and there is a huge frequency dependence of resistance, this sloping of R5 minus R19 that we can see here. And so in this setting, FOT has told us that this patient may have a very significant peripheral airways disease despite having relatively preserved spirometry. The next question is, well, actually, does that stack up in population studies? And the only large population study that's been conducted is this study, which was the ECLIPSE study. This is a 3-year longitudinal progression study in COPD, looking at biomarkers of progression of disease. The study recruited primarily patients that were Gold 2 and above, 2,054 patients with COPD, but there were a smallish cohort of current cigarette smokers or ex-cigarette smokers with a 10-pack year smoking history, 322 of those, and a small group of 233 patients that were non-smokers, no history of respiratory disease, less than 1 pack year of exposure. And what you can see is that the FOT here tracks the, this is the R5 minus R20, just tracks the COPD gold stage in the COPD population, looking at stage 2, 3 and 4. And there's no real difference between smoking controls and non-smoking controls in this frequency dependence of resistance between 5 and 15, 5 and 20 hertz in this data. However, if you look more closely at the data, I told you that the R5 minus R20 and AX track with gold stage. They weren't actually related in this study to overall emphysema burden, but remember that's not the same as looking at the distribution of the emphysema burden, so it doesn't detract from the message that I told you earlier in asthma. But in the smoking controls, just under 5% of patients had an elevated AX that was outside of the 90% confidence interval in the non-smoking controls. They had a normal CT scan with normal low attenuation area percentage, but they had a lower normal FEV1 when compared to those patients that had a normal AX. And perhaps these are the patients with early disease. And I think one area that's potentially very exciting is the use of FOT to evaluate early disease in people with very early gold stage COPD and then track its progression. Okay, what about other potential use areas? I think another area that's potentially very interesting to explore FOT with in clinical trials is IPF. We know that there is now a large number of potentially available antifibrotic agents, either licensed or coming through drug development in pulmonary fibrosis. We know that CT is the gold standard diagnosis of IPF within an MDT, but it's not widely advocated as a measure of disease progression. It's quite hard to deploy in that sense in terms of its cost effectiveness. We know that there are existing markers of disease progression in IPF. These include having a severe exacerbation of IPF and coming into hospital, a decrease in your forced vital capacity of more than 10% if you're on treatment, desaturation on a walk test, a 6-minute walk test, or a reduction in your DLCO, carbon monoxide diffusion coefficient, more than or equal to 15%. But what about FOT? This is an elderly population, median age 70 plus, find it very hard to hold their breath to do a DLCO measurement, find it difficult to exercise, to do a 6-minute walk test, and spirometry, they can do spirometry, but why not use FOT to evaluate disease progression in this population? I think that's a study that's waiting to be done. Certainly, I can see no reason why FOT could not be evaluated as a use case in an early phase experimental medicine study in IPF. Okay, so the final part of my talk in the last few minutes is where are we going with all of this? What are the future directions? Well, we've just completed a 400-patient study looking at the value of FOT in acute disease, and what we've learned from that is that we were able to deploy FOT in severe exacerbations. So these are patients in a hospital with acute cardiorespiratory exacerbations of either asthma, COPD, pneumonia, or heart failure, many of them on low-flow oxygen systems, and all of them could do FOT, and the vast majority of them could not do forced expiratory manoeuvres. So I think if you want to study lung function in acute disease, track it into the recovery in acute phenotyping studies or experimental medicine studies, I think FOT is a very exciting tool to use there. I think those of you that work with children in the preschool population, FOT has proven value there. I think the transplant population is very interesting, and there is data evaluating both FOT and multiple breath washout from the Warcock Institute in this population, showing that it's potentially useful. And that's from hematological stem cell transplant recipients. And also, I've mentioned throughout my talk the potential value in the very elderly population. I've got a number of collaborators who've taken FOT devices out to tropical regions to measure lung function in deprived or rural areas, particularly areas where there may be a high level of biomass exposure. So this is an area that potentially may be of value in taking a fieldable device out to get high quality lung function measurements. So those are some potential future applications. So what are the future directions? So I think FOT is ready for prime time in early phase, so phase 2 experimental medicine studies, certainly in asthma and COPD, and possibly in IPF. I think that there is more work to be done to develop FOT as a regulatory approved endpoint. It does not have anywhere near the wealth of normative data that spirometry has. But for those of you that are at the ERS and saw the pro-con debate between Ron Dandurand and Peter Calverley on FOT, and who've tracked this debate over the years, when a number of us have stood up and said that we think that FOT will probably replace spirometry within the next 50 years in respiratory medicine. A sharp intake of breath used to be taken in the audience when we said that 5 years ago, but actually this year at the ERS, actually it almost felt as though the audience felt that that was a given, which I found quite astonishing. I'm an enthusiast. Okay. Third point is that we should consider FOT as an adjunct to spirometry in our clinical centres. Why not use FOT? And I think FOT can certainly be deployed where forced expiratory manoeuvres are not feasible. I've talked about that. And with that, I'm going to conclude the presentation and hand over back to Chris for questions. Thank you.
Excellent, Professor Siddiqui. Thank you for that engaging presentation. Looks like we have a few questions that have come in from the audience, and audience members can also click on the Q&A widget at the bottom of their screen to submit questions now. Our first question. Is the result of FOT affected by upper respiratory tract infections, ear, nose, and throat, anatomical anomalies, or the like?
Yes, potentially. As I mentioned, the upper airway is an important potential confounder of FOT measurements. So the results will be affected if you haven't adequately controlled for the upper airway shunt. As you saw on slide 9 of my presentation, you do need to hold your cheeks and control for shunting. The shunt effect can be particularly pronounced in people who have very significant obstruction more distally in their lung. But as long as the shunt effect has been accounted for, the result should tell you primarily around or about the impact that the FOT signal has had on the lung and the lung airways. Now, of course, people with upper respiratory tract infection due to a virus may have viral particles that have gone into the lung, causing airways disease. Airways disease as well. That's something that can't be, I guess, answered in the question.
Great, thanks. We have another question here. Drug-related lung damage is seen in some drug mechanisms. Do you see a potential role for FOT to help pick up early lung damage to help demonstrate safety?
Absolutely. So I think drug-related lung damage due to drugs like methotrexate and so on and so forth is ripe for this technology. I've always struggled with, amiodarone being another example, I've always struggled with the use of diffusion measurements in this population, mainly because of the need for a 10-second breath hold, which can be difficult in this population. I certainly think tracking drug-related parenchymal lung disease with FOT is something that's worthy of further study.
Great, thanks. Here's another question from the audience. Standard spirometry is not really practical in children under 5. Can FOT generate suitable endpoints for this population?
The simple answer is yes. There are a number of studies that are published already looking at FOT in young children in the preschool population. In the large exacerbation study that we talked about, we actually looked at FOT during acute exacerbations in very early school age and some preschool children. FOT is feasible in children as long as the preschool children, as long as they're incentivized and appropriately trained to do the technique. It's a very, very simple technique for this population. I think that's really one of the great wins with FOT actually.
Awesome. We've still got questions coming in here. Here's another one. regards to cystic fibrosis. Has FOT been utilized in cystic fibrosis trials due to the heterogeneous nature of the disease?
It's really interesting that you said that. I asked one of my colleagues who has majored really in the development of lung clearance index in cystic fibrosis exactly that question about 5 years ago. And I think part of this is cultural, actually. You know, the CF field has heavily focused on the use of LCI and inert gas washouts as a regulatory endpoint in ion channel modulation trials. I just think it's a lack of use of FOT in this population rather than the fact that FOT would not be useful. In any lung disease, including CF, where you have a peripheral airway problem associated with major heterogeneous mucus plugging in the airways and bronchiectasis, FOT will be a very useful technique to measure both burden of disease and disease progression. Are there a wealth of studies in CF? The answer is no, and I think that the main reason for that is cultural and the fact that the regulatory environment has been driven by LCI.
LCI, that's lung clearance index, correct?
That's right, yeah.
Awesome, thank you. So we have another question. This one's on ALS. What is your opinion to use FOT for ALS? I'll probably pronounce this wrong. Amyotrophic lateral sclerosis disease. Could this also be a potential area for using FOT?
Yeah, and I haven't personally used it in this space, but I'm assuming that the question is arising because of the thinking around using FOT in tracheostomized patients. Can I query that question back? Because I think the answer will differ according to, you know, whether this is a patient with ALS that is dependent upon non-invasive ventilation, that has oropharyngeal and bulbar weakness, that will not be able to generate an adequate mouth seal around an FOT device, basically, versus a patient that, for example, may have a tracheostomy. What can the person that's raised the question just be a bit more specific about what they want?
Yes, they said they actually just submitted another response. They said, yeah, you're going in the right direction, what you were describing there.
Okay, so the answer is I think that a feasibility study needs to be done in ALS. I certainly think that patients that have very severe bulbar, pseudobulbar weakness may struggle to maintain an adequate mouth seal. But if they're able to overcome that limitation and they can generate an adequate mouth seal and they can maintain their head posture so that they have a neutral neck position, and they can either have a family member or themselves support their cheeks to prevent shunting, there's no reason why the technique couldn't be deployed in ALS.
Great, thank you. Another question that hopefully makes sense. It says, are there any contradictions to performing FOT or oscillometry?
I think that might mean contraindications, actually. So I'm going to assume...
I think it might have been a typo. You're right. Yeah, contraindication.
Yeah, I think it's contraindication. So FOT and oscillometry, are there any contraindications? The answer is no, because essentially with the tidal breathing techniques, which FOT is one of them, there really isn't a contraindication. I mean, essentially you're just breathing with a very small pressure oscillation applied to your airway. So there aren't any major contraindications as far as I'm aware. So the kind of contraindications that you have with spirometry that may mean that you will not do a test on a particular patient don't really apply to FOT, actually.
That's great, and there are no contradictions in that answer either. Okay, we have a couple more questions. This one's with regards to imaging. Can you outline whether FOT and imaging data can tell us the same thing or different things in asthma and COPD?
I think that as I said in my talk, the key thing that FOT measures is heterogeneity of disease in the lung. So if you have small airways disease, but it's homogeneous and essentially it's evenly distributed around the lung, You will not see abnormalities in these measurements, R5 minus R19, frequency dependence of resistance per se. The imaging seems to track very well with FOT when you have uneven disease. So as I showed you in the asthma data, if you have disease that's constrained to the base of the lung, i.e. ventilation gradient reversal, that's when we really see abnormal FOT measurements. And the same applies to washout. So in that study that I talked to you about in asthma, the things that really pull multiple breath washout data apart in asthma and FOT data apart, the small airway measurements within those techniques, is uneven disease in the lung. And it doesn't matter whether the gradient is from the bottom to the top of your lung or from the front to the back of your lung. Both gradients contribute to the abnormalities in these measurements. So I think, coming back to the direct answer, the FOT is capturing the heterogeneity of disease in the lung. So if you compare, as they did in ECLIPSE, FOT data to average low attenuation area data, you will not see anything. It's only when you look at the distribution of that disease and you measure that distribution, that's when there's a concordance between FOT and imaging.
Excellent. This one we've kind of already covered, but it'll probably be a good roundup for folks. The question is, you mentioned that a long-term ambition might be to develop FOT as a regulatory endpoint. Which disease areas do you think there is the largest level of evidence for FOT currently?
I think asthma is the simple answer. So I think there are, well over 100 studies of FOT, both observational and also now a mounting number of studies where FOT has been used in experimental medicine studies. A small number with biologics, but a reasonable number now with inhaled steroids. A number of them have been randomized, blinded and controlled trials. I think asthma is an area where FOT should be used as a secondary or exploratory endpoint in early phase trials. And that would be the natural starting point. I think early COPD is another area. And as I mentioned, I personally think that IPF is very interesting, but there's a lack of preliminary data at this point in time to suggest that FOT could track disease progression in IPF, or that it's superior to conventional forced vital capacity. But certainly that's an area that needs to be explored in more detail in IPF studies, I think, going forward.
Great, thanks. We have two more questions. This one is, in your opinion, when do you expect to see FOT as a primary or secondary parameter in clinical trials, and what needs to happen to get there?
I think that the one barrier for implementation and adoption in the clinical trial space is essentially large, robust normative equations like GLI. And that's going to happen the more that this technique is used across labs, across centres, across the life course. That GLI type of approach to having normative data for FOT will be there. I think there are other small issues that need to be ironed out. There is an international between lab standardization effort that's underway, looking at how all of the different FOT devices measure. There are also some efforts underway to look at whether you need to standardize the measurement with a standard reactance as well as a standard resistance. But these are kind of teething issues, and I think once those issues are out of the way over the next few years, I think FOT should rapidly progress towards adoption in early phase trials.
Excellent. Looks like just one or two more questions, and then we'll wrap up. When do you expect regulators to accept FOT data to support pivotal data for lung function pharmaceutical label claims? What is needed to get to this?
That's a really good question, and I'm going to declare my limit of expertise. I'm not a regulatory expert, and I do not have extensive expertise in taking TRL-based intermediate technologies through regulatory submission. But I would have thought it's a bit of chicken and egg. I think you need FOT as an exploratory endpoint in phase 2 asthma trials before you can then submit it as a regulatory endpoint. I think the examples that I gave you with Trelo and with Fevi multi-center and single-center respectively, are a step in that direction. In fact, those trials used a combination of techniques to study the peripheral airways that included CT and multiple breath washouts. I think that if you wanted to develop a regulatory package to look at the peripheral airways and peripheral lung disease with these techniques, I think the starting point is to get started with them in early phase experimental medicine studies. So I think we're a little bit away from that at this stage, but I think as momentum gathers in asthma, certainly I think that we're potentially within 5 years of that.
Excellent. The last question is actually in regards to ERT. They're asking if FOT has been used in any clinical trials supported by ERT. And actually that brings us to our final slide, which is that ERT does support the collection of FOT data in clinical trials. We offer the Thoracis TREMOFLO device, which can either be used as a standalone device or integrated with our MASTERSCOPE. And has all the benefits, of using FOT. It requires virtually no patient effort. Patients breathe normally into the device. The nice thing with the MASTERSCOPE integration is that you can manage the protocol workflow. So if you need to do spirometry, ECG, imaging, etc., you can control that. And obviously display the image and then transmit it back to ERT for display in our portal and for analysis and remote monitoring. So. Looks like we have no more questions, so I just wanted to thank Professor Siddiqui for his time today. It's been an excellent presentation. And just wanted to let the audience know that this webcast will be posted for on-demand access in the next 24 hours. And you can email events@ert.com to request a copy of the presentation deck, or if you have any additional questions or answers or would like more detail in regards to questions that you asked today. Stay tuned at ERT.com for upcoming webinars and other useful content on clinical trial, safety and efficacy, as well as trial oversight, site optimization, and patient engagement to help you minimize the risk and move forward quickly with confidence. Again, I'd like to thank Professor Siddiqui for his engaging presentation today. And this will conclude our webinar, and we hope that everyone has a great day. Thanks.